The following Ardelyx podcast is intended for informational and educational purposes only and cannot be considered as medical advice. Please speak to a healthcare professional before making any treatment decisions.
Hi, everyone. Welcome back to another episode of the Gut Matters podcast. I'm Johanna Ruddy. I'm Senior Director of Patient Advocacy at Ardelyx, and I'm joined by my co-host, Andrea Shin, Dr. Shin out of UCLA, a practicing gastroenterologist. And we have a very special guest today, Andrea.
Yes, super excited. Today we have with us Dr. Megan Riehl. Dr. Riehl is a leading health psychologist. She specializes in the management of GI disorders, including irritable bowel syndrome and inflammatory bowel disease. And she's an associate professor of medicine at the University of Michigan. She's deeply involved in GI organizations and in patient advocacy. Her research and clinical expertise have led to numerous publications, and one of her most recent achievements is co-authoring a book titled Mind Your Gut. And it's a book meant for people who are living with IBS, and was written with her co-author, Dr. Kate Scarlatta, who I believe has been on our podcast before. She is a much sought after speaker, and we're just so excited to have her with us today and, really get her insights on brain gut behavioral therapies and just the emotional impact of IBS-C. Let's, kind of get started on just this whole concept of the mind-gut interplay. Obviously, we've talked about this before, but irritable bowel syndrome falls under that category of conditions known as disorders of gut-brain interaction, implying that there's this very close interconnection between the gut and the brain and how these two systems can actually work together in contributing to the disease experience. And, we know that, a lot of feelings can manifest in the gut and vice versa. What's going on in the gut can have an emotional and mental impact as well. So I just wanted to start off by talking about that feedback loop with you, Megan, where physical symptoms can actually lead to emotional distress, which can in turn worsen symptoms. Just on that topic, when you, in your experience, what are some of the common emotional states that you see in your patients, and how do you feel like these emotions actually interact with their physical symptoms?
This is a great question and a really good starting place for helping patients to understand what you're describing as this bi-directional communication pathway between the brain and the gut. And I actually use a diagram, and we have it in our book too, called the GI stress cycle, where I'll show patients this circle that starts with maybe a physical symptom. So bloating, a cramp, a spasm, and how people that are living with IBS, especially with constipation, when you feel that physical sensation, it fuels this then cognitive response of, oh God, here we go again. I cannot this does not fit in with my day. What if I can't go? And as that cognition kind of ramps up, and it doesn't tend to be our most well thought out thoughts. These tend to be more of our negative, catastrophic, all or nothing thoughts. Then we begin to have that associated emotion. So when we're thinking that way, we begin to feel anxious, frustrated, irritated, stressed, angry. And as we have that emotional response, that ramps up what's called your sympathetic system. And this is your body's fight, flight, or freeze response. And we all have this built into us. But when this kind of innate system starts to kick off, all because of a cramp, spasm, or some bloat, we now are getting increased heart rate. Our breathing gets slower and shorter and shallow. Our muscles tense and clench and tighten. And as we have this sympathetic system response, it then starts to worsen our GI symptoms and perpetuate the cycle. And so our goal is to figure out strategies to break that cycle. We call them cycle breakers. And the good news is there are a variety of different ways, and we're going to talk about some of those later. But this feedback loop of how our thoughts based on physical feelings is really powerful and more pronounced in patients that are living with IBS.
At Ardelyx, we're dedicated to improving the lives of patients by discovering, developing, and commercializing first-in-class medicines that advance care to patients with unmet medical needs. Learn more about us at ardelyx.com.
I really appreciate that explanation because you're right. I think, to your point, those thoughts are typically not rational. They're usually quite unhinged many times, and this spiraling of the unknown that drives your anxieties, and then all of the physical ramifications that you mentioned with the muscle tightening and the heart rate, and even the so many people will say to me, like, when they're on the toilet, they end up sweating profusely, right? When they have cramping and bloating and pain during a bowel movement. And it's always been this weird question that you would even see written in like women's health magazines, like, why do I sweat when I'm having a bowel movement? Is that a real thing, or am I dying, right? And this like weird question and answer time. And I think this is such a nice way of explaining why this happens. With each of us have this response built in, right? But what can we do to address it and calm that response so it doesn't get out of control? You know, we've talked a lot in other episodes about the unmet need of patients living with IBS, with constipation, and the burden that this condition really has on day-to-day life for many patients, the decrease in quality of life for many patients. And a lot of our HCP colleagues will maybe not quite understand the impact that this has on patients for a number of reasons. And I feel like it's hard to understand it really if you don't have it. And so really trying to get a better idea of the burden and the impact can be challenging. But we know that it does have a connection to our thoughts, and our brain and gut are connected. And many times people will ask me, what comes first in IBS? Does the mental health component, or the depression and or anxiety related to the symptoms, does that come first after the diagnosis, or do those mental health kind of challenges drive a diagnosis of IBS? Is it chicken, egg, chicken? Like, what's happening? And I'm just curious, you know, from both of your perspectives in working in this disease state, what are you seeing, and how do you explain that to your patients and to your colleagues, frankly, who sometimes need a little refresher on this condition?
Yeah.
Yeah.
Well, I
Again,
guess
you can
if
go
I
first.
start
Yeah.
from kind of what my clinic looks like, and
Yeah.
and also in having lots of these conversations with my colleagues and other maybe physicians in the community that don't have access to an embedded GI psychologist, and they're kind of wondering the why would that person be in their practice. The first spot that I like to start with is, yes, the head is involved, but it's so important to validate that this is not fake. Patients aren't making their symptoms up, that they feel the way they're feeling. So if we go even back to the GI stress cycle, and the reason they have those thoughts associated with those symptoms is because it has had a profound impact on their life. And maybe that impact started when they were children, and they were at school and they were embarrassed to go to the bathroom, and they held it in, and then they came home and their stomach hurt, and, you know, they didn't want to eat, and then they're getting yelled at because they're not eating well, and the cycle perpetuates, right? Or maybe it's someone that developed IBS after a trauma, and they don't kind of draw that correlation between, you know, the body's shift and how it holds on to things after a psychological trauma. Maybe they've had an accident that was like a motor vehicle accident, and after that shifted the way their bowels were functioning. So Your answer is one in which it's we don't know what the chicken and the egg is because each individual is different. What patient A at 8 a.m. with me, what led them to an IBS diagnosis could be tremendously different from my 3 p.m. patient with
Right.
IBS. And that's what makes this so difficult and complex, and why often it requires this multidisciplinary approach. And also why some of our patients are just spinning their wheels because they've tried one thing and it didn't work. And they tried a different thing and it didn't work. And then they tried something else and it didn't work. And that hopelessness can breed anxiety and frustration, which can, again,
Absolutely.
right, we see the cycle. So I think peeling it back to really help patients understand this is oftentimes a multifactorial situation that has led to the symptoms that you're living with. And my biggest gift I hope to give patients is hope that even though it's complex, when you're working with a provider who can pull together some of these various interventions that may be of benefit to them, they can get better. We may not completely cure, that's not our goal. We don't cure IBS, but we improve the management and your quality of life. And it requires a team.
Yeah, I absolutely agree with that. And I think it's so important for patients to receive that messaging and that communication from their providers. That question about, what comes first, that's absolutely true. This is such a complex condition. And what we're dealing with is the outcome, the output.
Right.
But all the factors that feed into it can be a different combination of factors for different people. And because it is such a bi-directional, experience, it's absolutely expected that worsening disease or worsening symptoms can then, lead to worsening mood and increasing emotional distress. So the true answer is it's probably not just a one-way path for every person, and that's part of the process that we kind of have to be able to accept in order to then make meaningful progress. If we identify possible contributors and focus on what are the things that we can modify, what are the things that we can work through to help reduce, symptoms and give people more control over their lives. Sometimes we have to remind people these are chronic conditions, just like hypothyroidism is a chronic condition, but that doesn't mean that they're not treatable.
And I think helping patients to understand, and again, some of my colleagues, that the anxiety and depression that our patients experience can be very different. You can have those that are living with IBS and the bulk of their mood symptoms and anxiety is about their IBS.
Right.
And then we can have patients that have a whole host of other psychosocial stressors that are going on, and they have IBS. And so they have anxiety and depression regarding, multiple factors in their life. And that really also helps us with treatment planning. And introducing, again, some of the variety of interventions, but making sure that someone that may have anxiety, depression, unresolved trauma, that's not necessarily directly associated with their IBS, we're getting them the right care that they need.
Yeah. And that kind of brings us to the point of empathy. And I think so many patients really struggle feeling that their provider is providing an understanding environment of empathy and validation. And I think, I'd love to hear both of you on your take on the value of empathy and how to approach this kind of history gathering of the impact of these symptoms on emotional well-being. Because for some patients, they can tolerate the bloating and the abdominal pain, but they are just completely leveled by the fact that they can't, do all the things that they want to do with their children or with their spouse or their friends or their work. And that emotional impact around activity or lack thereof is really what's most concerning to them. So how do you kind of parse that out in a clinical visit, and how do you provide the empathy? How do you find out what's really driving their I guess what they're looking for in terms of management.
I think that this is such a challenging, experience that a lot of patients go through. A lot of providers, especially, traditional medical providers or physicians, even like myself, are very much trained in like a solution-oriented model where we want to identify a problem and we want to have the answer to fix it. And the reality of a condition like IBS, where empathy is part of the solution, that takes time. It actually takes some time to sit with the patient and ask them questions that you might not have immediate answers to. We may not have the immediate fix, but just taking the time to understand that in a way is very important for that interaction. So, as simple as asking, how does this affect your social life? How does this affect your ability to work? I might not have a prescription, in hand to have them interact more effectively with their family, but I do want to know about that because that can also help us prioritize goals when we come up with treatment plans. So they are somewhat open-ended questions, and I think that's also something that we often kind of shy away from because we're kind of working on a checklist of things, but we have to be kind of willing to ask open-ended questions and just take a little bit of time just to open that line of communication up.
Yeah, I think when I have a patient who is really feeling validated by their gastroenterologist, they will say, I was given a definitive diagnosis. I now know what this is. And then they told me about you. They told me about the dietitians. They are giving me options here, whereas, sometimes patients have lived with this for decades. And they're given a prescription and told, good luck, call me if you need me. Our medical system right now is not set up for, unfortunately, too close a follow when it comes to our physicians. And so I think opening that door of understanding that this is that the brain is involved, but you're not making up your symptoms. This is a very real diagnosis. It is complex. It can take time for us to arrive at the treatment plan that ultimately is going to get you to, I like to say, where you're going to live. And that way, when I'm seeing patients, I can, and they're trying different things and we're working the treatment plan and they're like, yeah, I'm still, I'm going to the bathroom 6 times a day, but I'm not completely evacuating. Or it was 4 days and I finally had a bowel movement. And as I'm looking holistically at the picture, I'm able to say, I don't think we're where you're going to live forever. I think we still have some work that we can continue to do. We're doing really good hard work right now, but we've still got time because people are looking for quick fixes.
Yes.
And when you're doing this the right way, there oftentimes are not quick fixes.
Yeah.
And so giving people the hope that their treatment plan and setting them up for realistic expectations over this is the long term. We might start to feel a bit better right away, and that would be amazing. But we're going to develop a lot of different strategies that are going to help you over time. And I think that helps patients to feel validated in their experience, that even though they would love, the magic intervention, we don't have that just yet.
Let's shift gears around the idea of IBS with constipation being such a stigmatized condition for patients. Even for patients who don't have a history of trauma in their past, tend to still feel very shy. I don't know, that's not the right word, but they don't want to discuss the symptoms, the physical symptoms, the how it even makes them feel. There's such a stigma around just bathroom talk in general. Probably, like, I remember as a kid, like, being told, like, we don't talk about that in public. That's not something that we need to talk about. That's private. So does it, Megan, as a psychologist, does all of this kind of start in our childhoods and in our families, and how this illness is kind of treated in a family dynamic that then kind of imprints on us our ability or inability to talk about these sorts of things, even with our doctors, who we should be able to do that with?
Yeah, it certainly can. I've sat with patients that I can see them almost starting to sweat as I'm asking them about their symptoms, asking have they ever digitally removed stool.
Right.
And the idea, like, sometimes I can just see them turning inward in embarrassment. And so sometimes I'm the first person that's ever said, look, this is normal stuff. I talk about this all the time. That it's okay to talk about, and then the stories start to come out around that concept that you're talking about, where I was never allowed to talk about bathroom issues. No one ever brought this up to me. People would make fun of the person that got up to go to the bathroom in school. I never wanted to use the bathroom, on the family vacation because somebody made fun of me. And sometimes just one thing can shift your whole experience with that. And we can see different times across the lifespan too. I've worked with lots of college students where they're like, oh my gosh, I have to poop in a dorm. That's so embarrassing. And, they're doing all these things to, and so I have 3 little kids, and whether they like it or not, like, they're getting de-stigmatizing language by proxy, because we're constantly talking about everybody poops. Toots are normal. If a friend toots in class, what would you do? No, we would never, make a comment. If somebody toots, you just ignore it and move forward. Like, all these bodily functions that we are all doing, we have to kind of destigmatize. And so, yes, some of this can begin very early in life, and it can be from either just families not talking openly about this, which we should. We
Yes.
should be asking our kids, how often are you pooping? How's it feeling?
Yes.
And then as adults, if something is not feeling right, your doctors deal with this all the time. So, it might feel anxiety provoking to bring it up, but you have full permission from us to do that.
Yeah, that's
Yeah,
great.
I totally agree. I think it's a pretty common scenario where patients often don't bring up their bowel problems, especially in primary care. It may be different for gastroenterology because obviously the reason they're there is for their bowel issues. But there is data that actually demonstrates that, people are more embarrassed to talk about their bowel issues than they are even about, like, sexual dysfunction and
Yes.
other matters that seem, highly private. I think that's just very revealing in terms of how much of this could be stigmatized. So yes, it starts very early on, and, our role as physicians, as providers, as members of the healthcare team, is to encourage and really make it apparent that we can talk about these things. It is very normal. We want to hear about it. These questions don't bother us. It might seem uncomfortable to you at first, but let's just try doing it. And over time, I think, that will make it easier for people to be honest about what they're going through.
Yeah.
And I think to help with destigmatizing and that empathy piece, the first time you meet a patient, they might not share the full story. Maybe the second time they're getting a little bit better and they might say, oh, I'm like, yeah, this is fine. This is fine. I'm going more regular. But it's our job to keep asking those questions. And, maybe you've gone from having a bowel movement once a week to, twice a week. And we want to find what the patient's realistic expectations for their treatment plan is. And Johanna, you brought this up earlier, like, what is it that you'd like to do in your life that
Right.
your bowel issues may be preventing you from? Because a lot of times patients are feeling like that's where they lose their control. They feel like they're being controlled by when the next bowel movement is going to happen and the symptoms that come along with that. And that then dictates, what time they go to work or when they drop their kid off or what they commit to and if they're going to travel. All these things that, if we're working together and communicating openly with each other, we can hopefully move in the right direction to giving them some control back.
Yeah. I think that loss of control is definitely the worst feeling as a human being, right? Like we always, particularly control over our bodily functions. And when we suddenly don't have that control and predictability, it can be really disorienting and make you feel really somewhat crazed, like I think about just my own recent health issues that I've been dealing with and lots of lack of control over a number of bodily functions, as well as lack of control over the future and treatments and just expectations in general. And I think that can be really anxiety inducing and somewhat depressing if you let yourself dwell on the negative impacts of your disease state, as opposed to, Megan, you mentioned earlier the importance of hope and instilling hope in patients. And I think that's so important. I'd love to, this is such great stuff, you guys, such great stuff. So I'd like to talk about some of the tools, Megan, that you've mentioned before. I know Andrea and I have had the opportunity to talk to some of your colleagues about these tools, but I just love them so much. There's so much great evidence to support the use of them. Andrea, what's your favorite tool in the psycho-gastro toolbox?
Yeah. So, what we're kind of talking about, I think this is very related to the topic of empathy and understanding the patient. But, one of our major goals should be to not only improve symptoms, but help people improve their overall quality of life, because that's oftentimes the reason that they're there. We focus on the physical, but it's really the whole big picture. And I think in recent years, there's just been a lot that has emerged in the field of psychogastroenterology. There's so many brain gut behavior therapies and so many other techniques that can be used to, boost and improve overall well-being. At our center, we have access to, trained GI psychologists who can, offer very specific treatments like gut-directed hypnotherapy, cognitive behavioral therapy. We have, I think there's a growing area as well, even just integrative providers who focus on things like mindfulness and stress reduction. I'm not, and Megan, you might have particular tools that you use, or there may be a certain strategy you follow to identify the best tool for each patient. But I'm kind of curious, do you use all of those different therapies, or are there certain ones that you find yourself using more often than others?
Yeah, so you bring up a good point of how do we decide what treatment plan may be best for which patient? And, I think when a patient is really identifying the stressful nature of both life and their symptoms, and they are stress sensitive and they feel, the effects of stress in their body, these can be great candidates for gut-directed hypnotherapy. And this is a type of therapy that works to retrain the way the brain and the gut are communicating, and using relaxation strategies that really get at our subconscious part of the brain, the part of the brain that does the things that we really aren't thinking consciously about, but subconsciously about, like our digestion. And so if you would have told me many years ago when I was in graduate school that I would be doing gut-directed hypnosis nearly every day of my career, I probably would have told you that you were nuts. But yet here I am. I've done several sessions today. And the sciences you were pointing to is really remarkable. In terms of patients that have not had adequate relief from other types of interventions that have been offered, can have anywhere from 60 to 80% will have improvements in their symptoms. And so this is really an ideal strategy where hypnotizability doesn't really matter. I know people kind of get caught up in like, I don't think that I'm hypnotizable, and like, I don't want to be walking around clucking like a chicken. But I like to kind of destigmatize that a little bit with this is oftentimes very comparable to an experience of deep relaxation. And also the language that you're hearing is more pleasant language about the calming and soothing functioning of your digestive tract. So I also will tell my patients that, I would suspect that you haven't been having the nicest conversations with your gut lately. And so what might it look like if we were having some different conversations? And then just by kind of the other very commonly used intervention is the idea of GI-specific cognitive behavioral therapy. And so I might start with that for patients that they've already identified that they're catastrophizing about their symptoms. They become very avoidant of life situations because of their symptoms. And so we're going to dive a little bit deeper into, how do our negative thought patterns influence our behaviors, and how do we work to shift that and change that using very specific techniques from CBT. And so, not every patient is going to be great for CBT, and not every patient is going to be great for gut-directed hypnosis. But one area that I do kind of use and pull from for almost everyone is, some of our mindfulness-based relaxation strategies. Because I firmly believe that there isn't a single breathing human that doesn't benefit from learning diaphragmatic breathing. And kind of, the power of tuning in to the body in a given moment and shifting some of that energy and tension. And we can do that rather quickly with deepening our breath and slowing that down. So there's lots of tools and as I'm sure my colleagues have shared, our treatment is not meant to be lifelong therapy. So our goal is to get you feeling better, fill the toolbox, maybe do booster sessions here and there as life happens. But this is very different from that more traditional general mental health work.
Can gut-directed hypnotherapy and GI cognitive behavioral therapy, can both of those be accessed virtually or in some other format, or is it best to do it in a face-to-face session?
Well, this is, again, not that the pandemic was a gift in any capacity, but we were doing a little bit of virtual therapy prior to the pandemic, given the idea that sometimes patients were literally like stuck at home with their symptoms and didn't want to drive 2 hours for their therapy session. And so we started some virtual therapy. I will be honest, our clinic is still 100% virtual. So we have done, there's also been data and science and research that supports that these types of interventions are just as effective, whether they're delivered in person, virtually, or even in group settings for many patients. So I think that has been very helpful in increasing access and getting patients to complete, the recommended number of sessions. And patients ask that. They're like, are you sure this is going to be as effective? And for many years now, we're seeing comparable results.
Well, I know that I have given your video on diaphragmatic breathing on YouTube to probably 1,000 people over the past decade. And I can fully attest that I have utilized it many times myself over the past several months, and it is highly effective at just calming that anxiety response prior to something that is anxiety inducing, or just kind of helping you relax before sleep or anything. So I think that is a great tool. So if our listeners would like to just Google Megan Riehl deep breathing on YouTube, it'll pop up. It's there, and it's a really nice short little exercise to work through. This has been really, really helpful. I think as we close out the show today, the big takeaways that I've gained from the two of you is that IBS with constipation is not a nuisance condition. This is a true diagnosable condition that has a very deep impact on patients, on their quality of life, on their emotional well-being, and really needs to be managed effectively with empathy, support, validation, clear communication, and education for the patient to better understand what's driving these symptoms, how they are affecting their quality of life and their emotional well-being. And then there are many tools available for patients and clinicians to work together to decide what is the best fit for them. A holistic approach. We've talked, Andrea and I are always like shouting it from the rooftops. It has to be everything, not one or nothing. So I think that's a great point to emphasize too. But as we close out, I'd love to get, we always try to get like a clinical pearl of wisdom for patients and or providers. So, what's one thing you would like to leave with our listeners today, both our patients and our practitioners, Megan?
Yeah. Well, one fun thing to do is just to do a quick check-in with yourself right now. Drop your shoulders, notice where your breath is, and recognize that none of us are immune to the effects of life and stress. And so, subtle techniques that, you have within you are so powerful, and they can just be a stepping stone to then, maybe thinking a little bit more clearly about what the next thing in your day needs to be. Maybe that's advocating, maybe that's making a phone call, maybe that's, deciding you're going to be open, really open with your medical provider at your next appointment. But either way, dropping those shoulders and taking a nice deep breath is going to be a nice way to wrap up a podcast for anybody listening.
Yeah, I agree. Andrea, what about you?
I think one simple message I would have is just to remind people, don't be embarrassed to talk about your bowel symptoms. It might seem uncomfortable at first, but your physician or your provider, whoever's sitting right in front of you, that is very normal to them. And, if it is affecting you emotionally as well, it's completely normal and okay to share that. So you don't have to do this on your own.
Yeah, absolutely. Everybody teeps and everybody poops. I think that was the lesson that we gained today from Megan's kiddos. So that's great. We didn't get a chance to speak too much about Megan's new book, but we're going to put a link to that book, Mind Your Gut, in the show notes so that listeners can check that out too. It's a really great resource for patients living with these conditions, as well as for caregivers, family members, and practitioners. So we'll make sure to link that in the show notes. Always lovely to see you both, my friends. Have a great rest of your day, listeners, and we'll see you next time. Bye now.